Good evening, everyone, and welcome to the December meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter, along with Dr. Amy Cipolla, who should be joining us a little bit later on. So tonight, we're excited and honored to be hosting Dr. Rebecca Knackstedt, MD, PhD, for her presentation on prehabilitation in breast cancer surgery and reconstruction. And I'm excited because of the inherent interest and relevance of the topic, but also because we've been trying to make a point this year anyway of organizing talks on important but possibly less familiar, less commonly presented on IM topics. And I'd say tonight's talk clearly falls into that category. And we have others of similar character planned for the coming months, so please stay tuned. And consider joining our free mailing list to keep apprised of our events. I hope to have a link in the chat for you to be able to do that a little bit later on. And I also say honored because Dr. Knackstedt is both a respected authority and a true pioneer in this field. And we appreciate her willingness to present for us this evening. So tonight's event was organized by one of our chapter's 3 leadership associates, Fiona Fragaman, an M4 at the CWRU School of Medicine, who this year is spending a year as a research fellow at Cornell Medical School, Department of Plastic Surgery in New York. And so in a moment, I'm going to hand the meeting off to Fiona to properly introduce Dr. Knackstedt and tonight's topic, and she's helming the Zoom as well. So any comments or questions, please enter them in the chat, and we'll get to them after the presentation. I have just one thing to add before I do have Fiona take over, and that is to say that one of our former student liaisons to the Case Medical School student body, who is now thriving in her residency at a rural hospital in North Carolina, I believe, sent me a somewhat distressed email when she was going through her own surgical rotation at Case. And this email highlighted some critical feedback from one of her surgical supervisors saying essentially, Olivia, you're spending way too much time talking to your surgical patients about nutrition. Keep your focus on the surgical aspects of their care. And Olivia, she seemed relieved to hear that it sounded to me like she was doing exactly what she should be doing in the best interest of her surgical patients. And I feel confident that Dr. Knackstedt had been her supervisor, she never would have received any criticism of the sort. But we'll find out more about that in just a moment. And so with that, the floor is yours, Fiona.
All right. Thank you, Peter. I appreciate it. Well, I'm just going to give a little quick tidbit of Dr. Knackstedt's background. So Dr. Knackstedt is a board-certified plastic surgeon and assistant professor at Duke University, where she focuses on breast reconstruction and prehabilitation for breast cancer patients. She completed her MD PhD at the Medical University of South Carolina and her plastic surgery training at the Cleveland Clinic. And she also earned her certificate in functional medicine at the Cleveland Clinic. She has published over 90 peer-reviewed studies and is nationally recognized for her work with integrating wellness and surgery. Dr. Knackstedt is someone I deeply admire, and I hope to blend these same fields in my own career. Surgeons are often among the most cautious when it comes to nutrition and supplements as well as metabolic health, but Dr. Knackstedt is a true pioneer in challenging that mindset. Her work emphasizes preparing patients for the best possible outcomes before they enter the operating room. Today, she'll be discussing her functional medicine approach to preoperative care and how integrating nutrition, exercise, and health empowers patients, improves recovery, and changes how surgical teams think about preparation prior to surgery. So we're honored to have Dr. Knackstedt join us today. Thank you.
Thanks so much for that lovely introduction, and thanks for inviting me, Fiona. I'm going to share my screen, and we'll have some time for questions at the end. So let's jump into it. Let's hide my panel. All right, can you see it okay?
Yep.
All right, is it full screen?
Yes, not yet.
Okay, Okay, there we go. I was on a delay. All right, perfect. So tonight we're going to be talking about prehabilitation and the fact that it is just more than exercise and nutrition. These are my relevant disclosures. And yeah, so about me. So I started my training at MUSC. I really wanted to do a PhD that focused on nutrition because that was really my passion. And I found a lab that worked on chemo prevention, and I had mice with bloody diarrhea for 3 years. But it really taught me to think critically, and I carried that into my plastic surgery residency and my microsurgery fellowship. And there I became certified in functional medicine. And now my practice is largely breast reconstruction and gender affirmation. So the goal of this talk is we're going to talk about the factors that contribute to quality of life and outcomes in a surgical patient. We're going to discuss how surgery and what I do really negatively impacts the quality of life in the short term. We'll then introduce the idea of prehabilitation and provide real good evidence that prehab can improve quality of life and outcomes in the short and long term in surgical patients. I'm going to be focusing on breast cancer patients because that's my patient population and that's where I'm going to get most of my literature from. But really the themes and topics we discuss can be applied to any surgical patients. So when we think about why we do breast reconstruction, we do breast reconstruction because it's been shown time and time again to improve health-related quality of life. And that's why it's covered by insurance and mandated that it's covered by insurance. But the challenge is that when we think about what impacts quality of life, when we step back and take a more holistic view, it's so much more than just your health. It's your life satisfaction, your independence, your family, and importantly, not just the absence of disease, but the presence of physical, mental, and social well-being. This is something that we use in breast reconstruction. It's called the breast Q, and it's basically the gold standard in assessing quality and outcomes in breast reconstruction. And you can see that when we look at quality of life, it's not a complete view. It's very, very narrow when we think about the holistic quality of life. So what I started to think about as a surgeon was, do I have a responsibility to care about the other things that impact quality of life? And what if I'm making some of those worse by the surgery that I do? And importantly, can I improve those things? Let's talk about what impacts outcomes and quality of life in a breast cancer patient. So for those of you who know anyone that's had breast cancer or treated for breast cancer, it's this really long drawn out pathway. They get this diagnosis of breast cancer, which is life altering. For many patients, they have neoadjuvant chemo where they gain fat, they lose muscle, they're sick, they lose their hair, and then they go on very soon thereafter to have a mastectomy or a lumpectomy where we're removing their breasts. They're in pain, they're on narcotics, they're having anesthesia. For many patients, they then go on to have radiation, which is painful and distorts the reconstruction and sometimes leads to a reconstructive failure. And especially if patients have implants, they pretty much have surgeries for the rest of their lives. And during all of these surgical episodes, they're missing work, they have activity restrictions, they're in pain, and this is their whole life. And this is if everything goes according to plan, because all along we're fearful of these dreaded complications, which are very high in breast reconstruction, but completely derail this course. This is a schematic that I drew. I can cut straighter than I can draw and paint, I promise. But all of these things that impact outcomes really interplay with each other. So things like nutrition, muscle mass, pain, all of these things feed on each other. And as a plastic surgeon, all I'm really impacting are the body image changes. And if you just think about stress and depression, there are so many things for a breast cancer patient that is just amplifying her stress and depression. And then surgery. Yes, I'm doing reconstruction because I think it's going to impact her quality of life positively, but in the short term, it definitely impacts it negatively. She's taking time off work. She's avoiding social interaction. She's in pain. She comes to my clinic every week, which takes time, costs money. She can't pick up her kids because of activity restrictions. So in the short term, her quality of life sucks. So even if these are temporary, what if I could improve them? What if I could make that short little blip of misery a little bit better? So let's talk about an example. This is one of my own patients. Her name is ST. She's a 30-year-old healthy female who was diagnosed with left breast invasive ductal carcinoma in 2022. She was one of my early patients. Due to her tumor location, she was not a nipple-sparing candidate, so we knew that we were going to have to remove her nipple areolas. She did want to be bigger than her current breast size, so she came to her clinic with her husband, her stepson. She currently wasn't working, but she used to work part-time for FedEx. Her mom also had breast cancer, so we talked about the plan, and the plan was to proceed with a bilateral skin-sparing mastectomy, which means removing the nipple areolas and tissue expanders to expand the skin to ultimately allow for implants. She had a rough treatment course. She was enrolled in one of our clinical trials, which involved preoperative breast and axillary radiation. She got some immunotherapy and then chemo. She had her bilateral mastectomies with her tissue expanders. Her nodes were positive, so she had to go back and have an axe dissection. And then during this time, she just wasn't healing the way I would expect her to. We got her through radiation. You can see this is what her radiated chest looked like. You can see her scar coming out of her breast. And it just wasn't healing the way that I thought it would. But when you think about the social events that happened during her treatment course, things we don't often consider as surgeons, it was tremendous. She lost her weight, her hair, she gained weight, she lost both of her breasts and nipples. From a family perspective, her husband filed for divorce. He sued for frozen embryos because he didn't want her to have any more children. Took away her stepson. She lost her health insurance because he was the provider of health insurance. Her mom was given months to live for metastatic breast cancer, and her mom lived in New York, but she didn't have money to go visit her. She had no money for a lawyer to fight all of these things. She couldn't afford medical care, transportation, and she was basically homeless. So with all of that, it's somewhat not surprising that these are the pictures I got when I was on vacation. She was in the emergency room with bilateral exposure of her tissue expanders needing removal. Her body was simply under too much stress to heal. And while this is kind of an extreme example, it's really not that crazy. Some of the comments made in clinic are absolutely shocking. People with very unrealistic expectations or going through divorce or family death due to, BRCA and PTEN mutations. So these women are going through a lot. And once again, these are not things that we're assessing as surgeons. So let's start with the problems. What is negatively impacting outcomes and quality of life? And then we'll move on to the solutions. You need to think about the physiology of surgery. And I think even as surgeons, we forget this, but surgery is a catabolic experience. Patients go into this extremely catabolic experience not having eaten or drank anything for the last 12 to 24 hours. Their glycogen stores are used up quickly, so then they rely on gluconeogenesis. When you have that rapid gluconeogenesis, this leads to insulin resistance and hyperglycemia. Because you're having surgery, you're acutely inflamed. There's a crazy decrease in micronutrients that happens. And then all of this is associated with muscle loss, which we'll talk about is critically important. And that's because amino acids, which are your building blocks for muscle and proteins and healing, are simply removed from the muscle to allow for healing. And then this is compounded by high cortisol, which leads to reduced protein synthesis and increased protein breakdown. And for my patient population, breast cancer patients, they're malnourished. Studies have shown that up to 50% of women with breast cancer are sarcopenic, and sarcopenic is extreme muscle loss. This was a study that looked at patients at their first medical oncology appointment, so even before they began chemo, and you can see the very high rates of cachexia, precachexia, and inflammation even before they started treatments. And neoadjuvant chemo significantly worsens malnourishment. Almost all women develop some aspect of metabolic syndrome. We always tell patients don't lose weight during chemo, but what we should tell patients is don't lose your lean muscle mass and gain fat, because that's what almost all women experience. And we know that malnourished patients have bad outcomes. Sarcopenia, or that loss of muscle, has actually been associated with mortality in women with breast cancer. So it is incredibly important even in the long term. But I'm a surgeon, right? So what do I care about? I obviously care about those things, but preoperative protein stores have been associated with increased morbidity, delayed recovery, and worse surgical outcomes. In breast reconstruction, this has been most profoundly demonstrated in free flap reconstruction. Free flaps are where we use a part of your body to make breasts. So it's like a self-transplant. It's a big surgery with a long recovery and a lot of healing. So somewhat not unexpectedly, sarcopenia has really been associated with negative outcomes. And this was a study that looked at physically fit individuals and put them on bed rest for 3 days. And just after 3 days, there was a significant loss of endurance performance, 3 days. And then what they found is that when these patients had bed rest for less than a month, it took a month to get back to baseline. And that was with physical therapy and guided restoration of physical fitness. And once again, these are in athletes who have a baseline high fitness. And if anyone's ever rounded on patients, like this is what patients look like in the hospital. They're not moving. They look like a melted snowman. So this is even worse in our patients. Let's move on to pain. Pain is one of the most common and distressing side effects of breast cancer treatment, with up to 60% of women experiencing this. And unfortunately, it doesn't go away. Some women experience this for years after their mastectomy. As you can imagine, this really negatively impacts their daily lives and can worsen things like anxiety, depression, and sleep. When we think about stress and anxiety, they often coexist with depression. And as a reconstructive surgeon, sometimes I make it worse because so much of their breast cancer course is dictated. You need chemo, you need an axe dissection. And then they come to me and I give them this whole buffet list of options: direct to implant, flaps, tissue expanders, Goldilocks, fat grafting, nipple reconstruction. And for some, all of those choices actually increases their stress and anxiety. And stress and anxiety has a significant metabolic downstream effect. It increases cortisol. It decreases your sleep quality. It leads to dysbiosis. And it's associated with a decreased tolerability in response to chemo, persistent pain, and somewhat not surprisingly, a decreased quality of life. Once again, I'm a surgeon, so what do I care about? Stress has been shown time and time again to be associated with complications, decreased functional recovery. On the flip side, optimistic outlook has been linked to improved postoperative outcomes in surgical patients. Specifically for breast cancer, the body image changes can be hard, and somewhat not surprisingly, up to 70% of women experience these body image concerns. But when you think about what they're going through, it's somewhat not surprising. We're removing an organ that's associated with femininity. For the most part, they're insensate or they have spotty sensation. This picture of this woman, it was a front page article in the New York Times, maybe like 6 years ago. And she talked about how grateful she was to have survived breast cancer, but she couldn't feel her kids hugging her. And that kind of launched the idea of sensate breast reconstruction. But it was the first time that that idea ever got media attention. And when you think about all the body changes after breast cancer, it's more than just their breast. They're gaining weight, they are losing their hair, they have scars, they have pain. So it's really impacting their whole body, how they see themselves. And even my best breast reconstruction is not the same as her native breasts. It's often insensate. There's no erogenous sensation to the nipple areola. There's definitively scars. If she has implants, she feels like there's something foreign in there. And there's always the concern for different surgical complications. And there's so many times when I want to say to a patient, if she's not super satisfied with a reconstruction that I think looks amazing, you just want to say, like, you had cancer, right? Like, I made these things out of implants. How do you not realize that they look amazing? But when this is kind of the epitome of femininity and beauty in our society, you can really understand why they just want to feel like they felt before surgery. Moving on to sleep, we all have bad sleep. And if you're not a resident yet, just wait till you're a resident. You're going to have really crappy sleep. But breast cancer patients have bad sleep. And it's for the same reasons that we have bad sleep, felt too hot, felt too cold. But it's also things like worry, concern, and pain. And it gets worse during chemo. And then they have surgery. And if anyone here has ever had surgery, you know that it destroys every aspect of sleep. You're in pain, you're taking narcotics. General anesthesia decreases your sleep quality and quantity. Hospitals are noisy and loud, and the nurses bother you every hour, so you're not sleeping in a hospital. And then for reconstruction, I tell side sleepers to sleep on their back for about 4 to 6 weeks while their reconstruction is healing. And bad sleep is bad. Stress and anxiety can lead to poor sleep and vice versa. If you have poor sleep, you actually experience more pain, which then requires more narcotics, which negatively impacts sleep. Even after 1 night of sleep deprivation, you have reduced leptin, glucose intolerance, decreased insulin sensitivity. increased cortisol, and inflammation. It negatively impacts the microbiome, and once again has been associated with negative postoperative outcomes. This was a subgroup analysis of the women's nurse health study, and it showed that if you had too much or too little sleep, it actually had a higher all-cause mortality risk. Breast cancer can be very isolating. So when you're thinking about social support, it's not always the social network that a woman brings with her in the beginning. It can be very isolating, even from family members. It's embarrassing. People don't want to talk about their breasts. They are taking time off work. They don't feel well. They avoid social outings. And for some things like radiation, you're going to the hospital every day. So that takes a lot of time. This was a study that was done by the American Cancer Society, and what they found is that 1/3 of women with metastatic breast cancer reported moderate to serious concerns about feeling lonely. That's a lot. And it showed that after a diagnosis of breast cancer, you can see that women felt more connected to cancer patients and survivors and less connected, probably out of embarrassment, to colleagues and friends. And it really does take a village. There are studies showing that women with small social networks had less cancer treatment than was recommended. And these social groups actually could explain more of the quality of life outcomes than even the cancer stage. It's been shown to be associated with survival, where those with small social networks have a worse survival. And at first we thought, okay, well, it's probably just because they don't have anyone to drive them to the doctor's office, right? But it's actually been shown in mice models to be related to cortisol. In breast cancer models in mice, increased cortisol actually leads to increased metastases. And we all know that smoking is bad. But this study on the left showed that social isolation was on par with smoking for breast cancer specific mortality. That's insane. And then we should probably talk about recon, right? Because that's what I'm doing. And I think that I'm improving their lives. But during that time that they're healing, they need time to recover. They're taking time off work. There's pain, complications. All of this is not positively impacting their quality of life. Sorry, everyone in my household has had the daycare illness for like the last 3 months. So I apologize if I start coughing. So what's the solution? What can we do to improve outcomes and quality of life in these women? Anything? So when we think about the solution, we need to think about the problem and what we need to fix. And it's all of the things that we just addressed. And before we jump in, delayed reconstruction offers a unique advantage to optimize a patient. So when I do some of my free flap reconstructions, they schedule out a year. So these patients have a year to optimize their health, their wellness, their social networks. But this isn't a luxury if you've been told that you have cancer and you need to have your mastectomy in 4 weeks. Importantly, even 5 days of prehab has shown in the literature to significantly impact outcomes. So even if you find out 5 days from now you need surgery, you can still do things to positively impact your outcomes. Prehabilitation is an intervention before an event. So you've all heard of rehab, which is after an event. So prehab is just pre an event. In surgery, studies have typically used some form of nutrition and maybe some physical rehabilitation, usually just 4 days before surgery. Head and neck cancer has done this really well, and they've published a lot on this. They've shown that just a few days of nutritional rehabilitation can improve outcomes, get you out of the hospital, and these patients are sick to the point where prehab has actually been shown to impact mortality. Now, my ideal prehab model would be more than just nutrition and physical. It would be, yes, diet, supplements, but it would also be a more holistic approach: stress, anxiety, depression, sleep, muscle mass, and social network. That's really a holistic approach to prehabilitation. So let's start with nutrition, because I think that this has the most literature to support it. When you think about the standard American diet, that's not what you need to heal from surgery. That's not giving your body the fuel it needs to repair. What you need is really protein, healthy fats, and then a lot of different micro and macronutrients. We're going to go through some of the most important ones, but really this is a whole hour lecture even of itself. So we talked about the fact that surgery is catabolic, right? So catabolic means breakdown of protein. And then bed rest leads to a loss of muscle mass. If patients have open wounds, like a decubitus ulcer, they're literally just pouring protein out through that wound. So they are losing protein at a tremendous amount per day. Protein's needed for everything. It's needed for collagen, wound healing, the immune response. You need a lot of protein. So studies suggest that you probably need somewhere on the 1.2 to 2, probably more like 1.6 to 2 grams per kilogram of body weight. This is about 1 gram per pound of body weight. This is a lot of protein. If you've never tracked your protein, it's hard to get 160 grams of protein a day. So it does require some strategy and thinking ahead. And please, 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 please do not use this. This is not specifically related to Boost, but a lot of these pre-made energy drinks. So if you look at the first 3 ingredients, 2 are sugar, water, sugar, sugar. And then it uses an omega-6 inflammatory oil. Almost half of the carbs are from added sugar. And when you look at the different vitamins and minerals, they're all less than 50% of the RDA. We're going to come back to the RDA in a little bit, but just know that that is way too little. This is toxic poison. I literally throw it out when I see it in my patient's room. Omega-3 fatty acids are amazing. They are anti-inflammatory. They've shown to help collagen formation, improve tissue repair, and they actually generate these really cool molecules that are aptly named resolvins and protectants because they resolve acute inflammation. Omega-3s have been vilified, and they continue to be vilified because there were concerns that omega-3s increase bleeding risk. And when I see lists of supplements for patients to stop, omega-3s are always at the top of the list. But there have been several meta-analyses. The biggest one had 52 studies, 20 on patients undergoing surgery, and found that supplementation did not lead to increased bleeding up to 9 grams a day. 9 grams is a lot. You're going to go into AFib. So 2 grams a day is perfectly adequate to resolve the inflammation without going into AFib. Quick biochem flashback. Oops, sorry. So when you think about the omega-6s and omega-3s, they compete for the same enzymes. And yes, omega-6s are important too, but our ratio that we're consuming omega-6s and omega-3s is probably somewhere around 30 to 1 for an average American. We need to tip the scale back to omega-3s. So that's why I do recommend supplementation to tip the scale, and also because most surgical patients aren't having salmon the day after surgery. As a reminder, if you're relying on plant sources like flax seeds, chia seeds, very low conversion to the actual omega-3s you want. So you really have to eat a lot if you're getting flax seeds, chia seeds as your source of omega-3s. Probiotics are awesome because the microbiome's been linked to everything. It's been linked to psychiatric diseases, to cancer, to responding to oncologic treatments, to preventing infection. And large meta-analyses have shown that they decrease just about all complications after surgery. Most of these studies have been done, somewhat not surprisingly, in gastrointestinal surgery, but there are non-GI surgeries that they've also been found to be effective in. Patients always get confused about probiotics because there's so many strains and species, and what's the CFU? Importantly, what the meta-analyses showed was that if you're getting at least 10 billion CFUs, which is a big dose, it doesn't really matter what strain or species you need. You also don't need those fancy ones that guarantee that they get down to your colon or small intestines. You literally just need 10 billion CFUs. Arginine and glutamine are conditionally essential amino acids. So the amino acids are broken out into essential and non-essential, and that means whether or not your body can produce them. So essential amino acids are ones that you have to consume through your food. Conditionally essential ones means that you can usually produce them, but during times of stress, like surgery, your body can't keep up with demands. And arginine and glutamine are 2 of the main ingredients that all of the head and neck studies have used in their immunonutrition because they're important for so many aspects of healing. Arginine by itself tastes disgusting, so I usually recommend that patients use Jubin. I do consult for Abbott, but Jubin is a good option for arginine and glutamine. The unflavored one is the least offensive, but it's still pretty gross. Caution about supplements is that supplements are not regulated by the FDA. So supplement companies can pay for a third-party validation, and the price is passed on to the consumer. It ensures that you get what you're wanting and avoiding potentially dangerous fillers. And as someone who is launching their own supplement company in like 2 weeks, I will tell you that there's a lot of really crap supplement manufacturers out there. So that third-party validation ensures that you're getting actually what you think you're getting. I tell my patients that all supplements at CVS are now third-party validated, which is great. You don't have to do any research, but they're a little bit expensive. I buy my supplements on Amazon, but I know the companies that I trust. And this is a misconception that I see all over social media. They'll say, oh gosh, all Americans are eating enough protein. No one needs any protein supplements, or no one needs a vitamin C supplement. But we are not repleting. So it's not like you're going to the doctor and your doctor draws your blood and it's like your vitamin D is low, better take some vitamin D. We want to get you to supra-therapeutic doses because your body needs so much more than it did the day before surgery. And as a reminder, the RDA. So the RDA is set to prevent chronic diseases without that nutrient. So for example, vitamin C is to prevent scurvy. Unless you know a pirate, no one has scurvy. So when we're thinking about optimal health and wellness, it's like 5 times higher than the RDA. Very common misconception, but very different than just repleting. Let's move on to exercise. I don't think I need to convince anyone that exercise is good, but for surgery, it is really, really critical for a couple reasons. 1, it's going to create a protein reserve for surgery, and 2, it's going to improve the functional recovery, which we're going to talk about a little bit more. Studies have shown that it really can help recovery and health, and it's safe during chemo as long as you do it in a somewhat exercise supervised program. You know, your body goes through so much when you're going through chemo, including fatigue and muscle aches and pains. So it's usually recommended that you do it in somewhat of a supervised program. All right, so let's hammer down why we need that increased lean muscle mass. So the first is we need to provide a reserve. The muscle is going to provide the amino acids after surgery. So if you start out with a little bit more muscle, you have a little bit more of like money in your bank to take out. And then once again, you're not able to exercise after surgery, which further decreases your muscle strength. We always forget the muscle's an endocrine organ, but it really does regulate blood sugar. So if you have less muscle than you're used to, you're going to have hyperglycemia. And once again, it's going to help with functioning after surgery. It's going to help these patients get back to baseline, whatever that meant to them, faster. But everything's working against the patient. They're sick, they're tired, they're depressed. I give them activity restrictions, they're in pain, they have a gazillion doctor's appointments, and then they have the usual work-life family commitments that also prevent me from working out at 5 a.m. So what do? This has been assessed in breast cancer patients in quantitative and qualitative studies, and it basically supported what I just said. The reasons that they're not exercising are all of those reasons. Patients are overwhelmed, they're tired, they're nauseous, they don't know where to begin. So what if exercise is a hard no? What if you have a patient who's like, look, I'm not going to exercise, never did, never will, not starting now? Then you might want to consider some supplements that aren't going to build muscle, but they're going to decrease the expected loss of muscle. So this can be really important for patients who are on bed rest. Omega-3s, HMB, leucine, branched chain amino acids. It's like the only time I ever recommend branched chain amino acids. They're otherwise useless. Or protein. Creatine. I love creatine. If you follow me on social media, I do a post on creatine like every other day. It's perhaps the most well-studied supplement. It increases muscle mass when taken with resistance training. Creatine monohydrate is the most well-studied form. You don't need any of the fancy HCl or microionized forms. For muscle strength, about 5 grams per day is recommended. There's no evidence that it leads to hair loss. That's something that I see talked about a lot on social media. There was just a randomized controlled trial which showed that it did not lead to hair loss. Important, it will increase your creatinine, which is a marker of kidney function, but it's safe in people with normal kidney function. You just have to let your doctor know that you're on creatine or they're going to think you're going into kidney failure. Let's move on to pain. We know that acute pain predicts chronic pain. So if we want to reduce chronic pain, we got to reduce acute pain. And we're actually pretty good at this in breast reconstruction. We have ERAS protocols and long-acting nerve blocks, but still it's not perfect. And newer models of pain suggest that pain is influenced not only by biological factors like surgery, but also psychosocial factors like anxiety and depression. And studies have shown that some of the most predictive things of how much pain you have after surgery are how much pain you have before surgery and how much pain you think you're going to have. But the good news is that those are things we can fix with pain specialists and cognitive behavioral therapy, but we have to assess them before surgery to understand if patients need these interventions. Once again, there are things we can do that are low risk, potential reward. This is not the most exciting forest plot you've ever seen. I totally get that. But when you think about the things that this study analyzed, it's very low risk things. Guided imagery, meditation, and even if they have the slightest impact whatsoever on pain, it's worth it. Once again, risk reward. Gum chewing. Gum chewing is a hidden gem. One of the things that people complain about after surgery is bloating because their bowels just shut down from the anesthesia and pain medication. Chewing gum after surgery can encourage return of bowel function, even get patients out of the hospital faster. Choose a sugar-free version with xylitol, and you can prevent cavities at the same time. Let's move on to stress and anxiety. Once again, low-hanging fruit. Easy things that can decrease stress: music, aromatherapy, massage, even things like plants and flowers in the recovery room. Let's move on to body image. Once again, this is where I shine. This is what I can do. I can help people with their body image. But it's not perfect. Some people still don't like the way they look. This study looked at journaling. So they did one guided journaling, and what it showed that one-time exercise improved body image distress and appreciation for up to 3 months after. One time. I love journaling for so many things, but it's really great for this. Let's move on to sleep. Once again, easy things: melatonin, exercise, acupuncture, yoga. But I really do encourage patients to get their sleep hygiene routine established even well before their surgery so that they have tools and tricks to fall back on when they are in that, post-operative period where they're not sleeping. Once again, creatine. Creatine is awesome. Creatine has shown to help cognitive function after sleep deprivation. And what's more sleep depriving than surgery? You do need higher doses for this, up to 20 grams. I recommend 10 grams per day, and that's what I personally strive to take. I do break this up into 2 5-gram doses just to help with bloat and tolerability, but 10 grams per day, get those cognitive impact. Let's move on to social networks. This is where social media can shine or fail. So social media can be great for helping women find other people to support them. They have a group that they can ask those embarrassing questions that they don't want to ask their family or friends. They can find and connect with women who have similar diagnoses and treatment protocols. There's lots of resources on Facebook and different social media platforms, even things like Susan G. Komen, to connect with people virtually and get that virtual rally. What social media is not good for is asking your friends on social media if you should go to the emergency room with a red breast that's pouring out pus. I see that all too often, but this can be a really great aspect of social media. All right, overwhelmed, so are patients. The important thing is that this beautiful meta-analysis published earlier this year found that if you just do one thing, you still get meaningful outcomes. So they looked at 106 randomized controlled trials with surgical prehab. And what they found is that if you did many things, nutrition, exercise, psychological counseling, you have the best results. But even if you did one thing, just one thing, you still had positive outcomes and improved your overall recovery. And importantly, patients want to know. As surgeons, we often think that we're overwhelming patients, and we objectively are. But then we think, well, maybe we shouldn't give them any more information. They're already overwhelmed. This study looked at colorectal surgery cancer patients who had just had surgery, and they said, do you wish you would have had more information about what you could have done before surgery? And first off, the answer was overwhelmingly yes. But they also qualitatively asked patients for feedback. And some of the feedback that the patients gave was really interesting. They said that they would have felt more like a member of the team if they had something to do. And as surgeons, that's what we want. We want our patients to feel like they're part of the team. So I really love this study for both its qualitative and quantitative outcomes. So how do we teach patients? We don't have time in clinic. This is just getting worse with the current insurance landscape because I'm expected to see more and more patients in clinic. Most surgeons don't have any nutrition, exercise, and cognitive behavioral training unless it was a personal interest. And I will tell you that I've given this talk at a lot of grand rounds, and surgeons either love it or they look at me like I have 10 heads. I can't send my patients to dietitians because they're recommending Boost, and I'm just going to throw that away. Some hospitals have nurse navigators that you can refer patients to. Sometimes there's counseling that's an option at the hospital. But is there anything we can do? And I thought about this a lot from my own practice. And so what I did is I made this prehab guide. I'm happy to send it to you. If you want, just shoot me an email at the end or a social media message. But it really is a comprehensive look at what I want patients to do. It talks about things to prepare your house and how to get help with activities after surgery, how to have pain control, all the supplements I recommend. It's version like 3.0 at this point, but I try to update it as the literature evolves. And this is where I took to social media. I started an Instagram page like maybe a year ago. It's been fun to do, and it's also been a really great opportunity for me to be on like 20 different podcasts, talking to people all over the world and reaching people that I never would have had the opportunity to if I didn't use the pros of social media. So in conclusion, we can definitely improve outcomes and quality of life for our patients beyond just providing reconstruction. Importantly, we're not routinely assessing the patient factors that impact outcomes. And even if we can't fix the problems, we need to be aware of their impact on outcomes and maybe adjust our surgical plan. Prehabilitation is so much more than nutrition and exercise, and we definitely don't know the most effective interventions. We need so much more research, but until then, I think that we should adopt safe, low-risk, potential reward interventions. So thank you for listening. That's my email address. It's easy. It's just my name at Duke or rebecca.knackstedt@duke.edu. Those are all of my social media handles, and I would be happy to take any questions.
Thank you so much. That was a really wonderful explanation of practical things that patients can do, and then for the provider, where to start, because I think that that's something that's difficult. Peter, before I ask a question, is there anything you would want to say?
Well, I want to second your response. That was a wonderful talk. A tremendous amount of material and more than can be processed, so that's why we have the recording. But I also wonder if you, Dr. Knackstedt, would be willing to share your slides with the people who have registered. I mean, no pressure to do so if you don't want to, but we often do that along with the recordings if presenters are willing to. And in this case,
I'm happy to. I just have to remove those patient slides.
sure.
But and maybe when we upload them to YouTube, we could kind of just
blur it out. I got you.
But otherwise, I'm happy to share them.
Great. So
well, I definitely
we'll figure out how to do that later.
So you kind of alluded to this, but how have your surgical colleagues responded to your incorporating prehabilitation into the standard of care that you've set? And do you feel that there's growing interest or more resistance?
That is an excellent question. So what I have found is similar to how my patients adopt it. It's splits where patients and surgeons either go all in, and by that I mean they're the ones who are inviting me for grand rounds and they're really interested and they want my prehab guide. And they're the patients who message me at 2:00 in the morning and are like, are these the right supplements to be taking? And then other surgeons and some of my own partners have literally unfollowed me on Instagram because they truly do not believe what I'm telling patients. Mm-hmm. And I think that it stems from a couple reasons. And I've talked with a lot of my surgical colleagues about this. One is, if you do something new, you're admitting that what you did before wasn't the best that you could have been doing. And that sucks. I think that even when I started my own practice, what I recommended was different than what I recommend now. And looking back, I'm like, gosh, I really missed an opportunity with a lot of women to take this more holistic approach. So I think that's the first thing is you're recognizing you could have done something better. And we don't like that as surgeons because we have big egos. And the second thing is that it takes time and thoughtfulness to implement something new into your practice, whether it's having a handout or having videos or talking to patients about that. That takes time and energy, and doctors are at a loss for time and energy right now. The third thing is that the challenge with alternative medicine and functional medicine is that there's a lot of truth in what we do. There's randomized control trials to back up the evidence that we are giving to patients. But you have a lot of quacks out there who are selling snake oils and making a profit off of fear-mongering posts and giving vulnerable women more things to be afraid of. And then, they sell their supplement that's going to cure their cancer. And so when you see that, when that's your exposure to functional medicine, as a conventionally trained doctor, you just lump all conventional holistic into this voodoo bucket, and you can't get the nuggets of truth from it. And so that's really what motivated me to start my Instagram page, is that I'd see so much misinformation from functional medicine providers, chiropractors who are profiting off of this. And so very long-winded answer to your question, but I think that there is increased interest within plastic surgery. So many private practice plastic surgeons are starting a prehab clinic for a couple of reasons. One, patients are asking, and if they want that information, they're going to pay to get it somewhere, so they might as well pay to get it from you. And then two, I think that surgeons are realizing that those things impact your outcomes. And if you're trying to sell a tummy tuck for $30,000, you want your patients to have no wound healing complications, beautiful scars, and you can get that through this holistic approach. There's been, at our national meeting last year, I was on a panel. So I think that there's growing excitement. The challenge is that surgeons love data, and I don't really see a whole lot of randomized control trials being done on music therapy in the next 5 years.
Yeah, no, I think it's very true. It's definitely what I saw through my rotations and in the hospital right now as well. So I appreciate that insight. We actually have a question here. Do we have anything for Lars syndrome, also for inability to digest proteins and fiber post-chemo in colon cancer?
I won't tell you, I don't even know what Lars syndrome is.
Yeah, I don't know what that is either. I've never heard of that.
But I think that, so my foundation of knowledge is very niched into largely healthy patients. Most breast cancer patients that come to my door are healthy, or they wouldn't be considered reconstructive candidates. So I always for, sick patients who have malabsorptive issues, really complex medical issues. You got to find a dietitian who's going to treat you in a holistic way, who's not going to recommend to lose weight, you go on a 600-calorie diet, or give you a diet pure supplements and things like that. You need to have someone who's going to talk to you about incomplete versus complete proteins, the importance of healthy fats. And I think that's going to become even more relevant, that type of evidence-based nutritional counseling, that when every person in our country is on a GLP-1, because we're going to have an epidemic of sarcopenia in our country. So I think that if you have those types of medication-induced malabsorption or anorexia, or from a medical condition, you got to find someone who preaches evidence-based practices.
Yeah, I would agree. Another question, what do you do when there's limited evidence in a guide to clinical decision-making in prehabilitation or functional medicine? I find that to be a struggle personally, and I was wondering where you sat with that.
That's such a good question. For example, when I made my list of supplements, some of them are based on randomized control trials, like probiotics, protein. Some of them are based on core observational data, vitamin C. Some of them are based on animal models and knowing that certain micronutrients are important for healing. So when I think about the data that I need, first off, I think we need to have transparency with data. So you'll go online and you'll see all these posts that Manuka honey cures breast cancer. And it's like, yeah, in a mouse, if they're eating 1,000 calories of honey a day. So when we give information like that, we need to clarify the quality of the information. This is coming from an animal study, but the animal study showed. So that's the first thing, I think, is clarity of data. The second thing is the risk benefits. So is there a beautiful randomized control trial that I can hang my hat on for acupuncture? No. Are there some small cohort studies that have very low risk apart from the cost? Yes. So for a lot of these things, it's definitely risk benefit analysis. And then just, deciding with you and your surgeon or your healthcare team what are acceptable risks to you and the benefits that you're trying to achieve.
Yeah, I would agree. I think it's kind of a in between place where, sometimes things are logical too. Like, oh, sleep is important.
Right.
Like, why do we need to study? Why do people need to be convinced that that's something that's important? But
Exactly.
at some level, evidence is important, and doing nutrition-based studies is really difficult, and doing these studies to prove that is really difficult.
Absolutely. I mean, I'm a consultant for Abbott, and we've been trying to design a clinical trial looking at Juven pre-deep flap reconstruction. And I mean, it's been months of we're going to need a huge cohort because you need to consider baseline diets, baseline, metabolisms, and genetic. And it's hard. It's very hard to do human interventional trials.
Yeah. Peter, do you have a question to break up my line of questioning? I have some more.
I actually was just going to say that on the problem of evidence, that's why we have things like the Academy of Integrative Health and Medicine and the fellowship and so on. I mean, there is so much bad and commercially motivated, profit-oriented information, as you said, Dr. Knackstedt. But there's also like a tremendous, I mean, as far as I know, there's a tremendous amount of research that's being done in all quarters, all over the place, beefing up evidence for this intervention or that intervention. I'm not just talking about surgery, but just in general, the whole integrative medicine movement, the whole functional medicine movement. There's like a ton of research that's being done all the time to like beef up the evidentiary store. So it's not like a wasteland out there. It's just sort of the opposite. There's like there's so much material that it's easy, especially for lay people, to get confused about what's reliable. And also looking at the right place. They're not looking at journals that are doing controlled studies and so on. They're looking at popular information that's on the internet. So it's difficult. But I mean, there's a lot of stuff out there is all I'm saying. It's not like we're in a vacuum.
Do you I know that you have this prehabilitation plan, which is so cool, and I definitely want to get my hands on that immediately. But I was wondering how you may tailor that plan to specific patients and what individual patients' needs are versus another. Like, how do you really curate your plan?
Yeah. So when I started my practice and I had all the time in the world, I would sit down with patients and like ask them about their diet and their exercise routines, and we would just like chat for an hour. And now I just like honestly don't have the time. So that's why it's unfortunately a little bit on the patient to figure that out. As a patient, you got to be an advocate. You have to be willing to ask the hard questions, advocate for yourself. And I think the good thing in breast reconstruction and cancer, at least, is that they are very empowered patients. They are very knowledgeable. They've done research. They've connected on social media with people. So they come in with good questions. And I love that. for me, when I'm thinking about my patients, the things that really impact my practice are whether they just had chemo, because if they just had chemo and then I'm expecting them to heal from a mastectomy 4 weeks later, like that's crazy. So we really have to double down on nutrition. And then the other thing is from an exercise perspective, I used to just tell patients like, look, just like increase your muscle mass. Like I don't care, legs, arms, core, whatever. And now I tell patients to think about what you'll be relying on after surgery. So for example, if I'm doing an abdominally based breast free flap, belly's out, breasts are out, arms out. So you got to build up your leg muscles because that's going to be how you're getting off the toilet for 4 weeks. So I tailor a little bit more for my patients based on what surgery they're having. Because once again, most of my patients are conventionally healthy or they wouldn't be having breast reconstruction.
Right. Yeah, it makes sense. Is there a specific exercise that you recommend? Is it more cardio? Is it more strength training, lifting? What do you tend to lean towards? I mean, weightlifting, you're going to build lean mass more, but
Yeah.
is there a wrong exercise, I guess?
There's no wrong exercise. You know, if I can get a patient who was basically, sitting on the couch all day to walk around the block before surgery, like that's a win. If I had the ideal prescription of exercise before surgery, it would be largely resistance training, which is hard for someone who grew up in the 90s where cardio was king and women don't lift weights because it makes you bulky. But there's so much evidence now for resistance training for every aspect of health and wellness. And so especially for surgery, like is zone 2 training healthy for life? Absolutely. But when you're thinking about preparing for surgery, I think you got to do things that are going to increase your muscle mass. So I love things like squats, even body weight squats, using the creatine to help build that muscle strength. But once again, it's meeting patients a little bit where they're at. And if it's going to overwhelm somebody by telling them they need to start doing like push-ups, then just walk up and down stairs.
Yeah. Thank you. All right, I have one more and then I'll open it to other people. So what was the one I was about to ask? Oh, I don't know if you've run into this. There's a study that looks at probiotics in relation to antibiotics and how it can actually lead to your microbiome not recuperating as quickly as it would without probiotics. And for patients who often are having preoperative antibiotics, when do you recommend giving a probiotic? And like where does that fall? Or someone who has an infection, like what do you recommend?
Yeah, that's an excellent question. To my knowledge, it was only like one study that showed that if you took probiotics at the same time as antibiotics, it delayed return of the microbiome, whereas most of the studies have shown that it's beneficial. So I tell patients, if you're taking an antibiotic, you should be taking a probiotic. You need to space them out by 4 hours because otherwise they just negate each other. So you got to let the antibiotic get through the GI tract before the probiotic comes along. But I recommend probiotics because you think about all the things that impact the microbiome. So we give everybody preoperative antibiotics, some postoperative antibiotics. You're in the hospital, so you're getting like weird MRSA stuff up your nose. There's studies now in animals showing that 100% oxygen, which is what we give to patients before we intubate them, actually ruins the microbiome. Narcotics. So all of these things are destroying your microbiome. So I do recommend probiotics despite that one study because I think that the overwhelming evidence is pro.
Yeah, and there was actually a follow-up question on probiotics in the chat. Are probiotics contraindicated in patients with chemo or immunosuppression?
That hospital. If you can if you're listening, I would be so curious to know what hospital that is if you feel comfortable saying.
They're somewhere in North Carolina, I know that.
So curious. Yeah, that's BS. So there have been meta-analyses looking at this. What I don't know that is. Is that in North Carolina? See that person who's typing? No, I'll have to look up UNC. Okay. So there are meta-analyses looking at this. And in that one that I cited, actually, of the 52 studies, I think that of them, there were 3 patients that became sick from the probiotics. But once again, you can't it's correlative, not causative, right? Like
It's
they're
not in a
immunocompromised.
vacuum.
Yeah. And so interestingly, to get on a soapbox for like a minute. So probiotics, part of the gimmick of those probiotics that say like, we're so expensive, we survive to get down to your GI tract, is because most probiotics are destroyed by your stomach acid. So by the time that they get to where you're going to absorb them and like hurt people that are immunocompromised, like they're dead. And so most probiotics are probably acting as postbiotics in our GI system. So they're not even alive. Now you might say, well, then, yeah, but then why wouldn't I spend the extra money and take those really expensive ones? Because all of the studies that have looked at probiotics and shown meaningful clinical improvement have used the cheap little ones that are dissolved in your stomach acid. So to me, that is hardcore proof that you don't need those fancy probiotics. Like they're doing something, even if they're not acting in the way that we think they're acting. And then they're not going to make immunocompromised people sick. So thank you for sharing that. That's very interesting. But no, that's crazy. Hospital policies are awful. We have a hospital policy that you can't give IV sticks and lymphedema arms, which is based on zero science whatsoever. So yeah. There was also another question about creatine. Yeah, so I recommend women do 10 grams. Women and men do 10 grams per day. Once again, almost all my patients are women. The studies for cognitive improvement have used either 10 grams or 20 or 0.3 grams per kilogram, which ends up being somewhere between 10 and 20. I'll tell you, it's hard to take 10 a day. Taking two, like it's like it messes with my stomach. If you can take 15, some people have shown that that actually improves cognitive function even better, so go for it, but it's also expensive. And then what protein supplement do you recommend for patients who say, I can't possibly eat that much complete protein and food? Yeah, I mean, a surgeon. Like I don't eat normal meals. So I super rely on processed proteins, which I know is not like the overall banner of health and wellness, but I always have a whey protein shake in the morning and I put my creatine in it. That's 35 grams of protein. I usually have at least one protein bar a day. I like beef sticks. I'm like a walking processed protein person. But I think that is that the best option for overall health and wellness? Like, no, I'd love if you had a grass-fed steak, but you got to meet patients where they're at. So for protein, I recommend whey to patients who are carnivores and will have animal products if they don't have GI distress from them. The whey protein isolate tends to be better tolerated than concentrate, especially if you have lactose intolerance issues. For vegetarians and vegans, I recommend organic soy. Hemp is disgusting, but it's a good option too. Soy and pea and hemp are like the 3 complete proteins. Because if you're eating incomplete proteins, then you need to eat even more protein. And once again, this is a lot of protein to get. Fairlife is a good option. My patients really like Fairlife shakes.
Yeah.
Premier Protein. What do you say to your colleagues who say meat causes cancer, increase in, how much time do you have? So those studies are awful. They're inherently flawed. Like the study that showed that if you have 50 grams of meat a day, you increase your risk of colon cancer. Those are observational cohorts, like diet recall. So super, super flawed. And once again, the challenge with all of these studies looking at meat products causing some type of cancer is 1, you're relying on dietary recall. 2, there's no differentiation between healthiness of meats, like a grass-fed steak versus like Walmart ground beef. So there's no differentiation between those. And then 2, since for so many years people were told not to eat meat, there's this user bias of people who are vegetarians tend to like do yoga and have a meditation practice, and people who eat meat have a higher rate of smoking. So it's hard to control for all of those factors. But my daughter has a salami sandwich for breakfast every day, so I hope that the data is okay.
Well,
Any
Peter,
other
do you have any
questions?
other thoughts? I know we've
Well,
asked a lot of questions here.
when I was studying these kinds of things, I did learn that red meat takes an inflammatory pathway, metabolic pathway, as opposed to a neutral one like white meat poultry, or an anti-inflammatory pathway like like fish and vegetarian protein. So even if you don't like studies that say that red meat causes cancer, are you saying also it's really not inflammatory?
So I think that it depends a lot on, so studies have shown that grass-fed meat has a higher rate of omega-3s versus omega-6s, same with eggs. So it's expensive. This is a really hard time to get groceries. I get that. But if you can prioritize higher quality cuts of meat, there are studies showing that if you eat cruciferous vegetables at the same time as the meat, then it can like somewhat neutralize some of those, concerning carcinogenic compounds potentially. So that's a really great option too. Or taking like a sulforaphane supplement. I love fatty meats, like salmon, things like that. Like that's a really great option. Once again, super expensive if you're buying the wild caught. I eat a lot of meat. I mean, it's like the only way I can beat my protein goals. And as we know, all like perimenopausal women now are being like pressured into like eating protein and taking creatine. So I'm just, following the bandwagon.
Did you run into any research about fiber? I know that I find that that you didn't mention fiber in your talk, so I don't know if you have any takes on that.
Yeah, I mean, there's so many studies showing that fiber is so critical for so many aspects of health and wellness, and most Americans don't get nearly the amount of fiber that we should be eating. So yeah, fiber has been shown to impact microbiome in a way that could impact chemotherapeutic responses. So yeah, that probably is something that I should add to my talk. But yeah, fiber. And if you can get your fiber through natural products like vegetables and oats and whole grains, that's more beneficial than just like eating a whole bunch of Metamucil. But yeah, fiber is so critical for overall gut health and for regulating blood sugar and metabolism.
I would agree. All right, I think that is all I have. Peter, is there anything else you wanted to add?
Not that I can think of at the moment.
Perfect.
So does anybody else have any questions at all or comments?
Wants my
Okay,
guide, or if you have any other questions, just feel free to send me an email, rebecca.knackstedt. I'm happy to share.
thank you.
All
Well,
right.
thank you so much for doing this. It's been great. And I mean, I, I think that people will really benefit from reviewing the recording, because there's a lot of stuff in there that you couldn't really get to, but it would be useful to see, and then your slides as well. So, yeah, I mean, just thanks so much for agreeing to speak to us.
Yeah, thank you so much for having me. It was really fun.
Thank you so much, Dr. Knackstedt. We'll be in touch.
Okay, talk to you guys soon. Good night.
Good night.
Bye-bye. So for